That's loud. All right, so anybody, they missed a little mindfulness, but that's okay. Let me share. All right. Can everybody hear me okay?
I've got you good.
Yeah.
Okay. Okay. I meant to ask that before we started. So we are going to start. This is our Women's Health Forum, Hamilton Women's Health Forum, Cardiac Health. That's this month. It's the American Heart Association declares February Heart Month. We have Valentine's Day on Wednesday. I'm wearing my red, which Red Day I think was last Friday. So let's get into it. Here's our little agenda. What is heart disease or CVD, cardiovascular disease? We're going to talk a little bit general definitions or explanations. We're going to talk about female-specific risk factors. We're going to talk about some symptoms of cardiovascular disease, testing and treatment, and prevention. What is heart disease? The term heart disease refers to several types of heart conditions. It's like an overall umbrella of all things related to the heart specifically and to our vascular system, our veins and our arteries, anything that is bringing blood to the rest of our body. These are some of the different disease processes that fall under cardiovascular disease or heart disease. So the number one is coronary artery disease. These are problems with the vessels that feed that heart muscle, those blood vessels that feed the heart muscle. That's when you talk about like heart attacks or open heart surgery. This is all related. That's a coronary artery disease. Arrhythmia, problem with your heart's electrical conduction system, and leads to abnormalities. You can have atrial fib or ventricular fib, but these are things that you have you have a fluttering, sometimes you feel it, sometimes you don't, but it obviously is not efficiently pumping the blood, and then there can be pooling of the blood, which leads to blood clots and then strokes. So heart failure, you'll hear someone say they have congestive heart failure or heart failure. That is not cardiac arrest. Some people get that mixed up. Heart failure is a problem with the pumping and the relaxing of that heart, and fluid builds up, and you can get short of breath because the fluid builds in your lungs. You can retain fluid in your extremities, mostly your feet. Valve disease, this is the valves that are in between the atrium and the ventricles of the heart muscle that are leaking. And so again, pooling of blood. Peripheral artery disease it's problems getting your oxygenated blood to your extremities, to your organs, anywhere like away from the body. Aortic disease, these are things like aneurysms where you have a weakness in the artery wall and it allows ballooning, or like think of like a garden hose that has a weak band in it and it starts to bubble. That is aortic disease. Congenital heart disease, you were born with something. Pericardial disease, these are things like myocarditis, pericarditis. That lining of the heart is infected, usually secondary to a virus. I know there was concern with the COVID vaccine in young men developing some of this. Further research has to be done on data collecting on that, but pericardial disease is a real thing and it can be very debilitating and dangerous. Cerebrovascular disease, this is the blood vessels that deliver blood to your brain. They narrow. This is where you may have a CVA or a stroke, cerebrovascular accident. That's a CVA. You have cerebral vascular disease. And then deep vein thrombosis, those blood clots that you can get usually in your lower extremities. And the problem is that those thrombosis, those blood clots will break off and then head somewhere to the lung, to the heart, to the brain, where they can then prevent oxygenated blood from getting there because they block. So those are our big cardiovascular diseases. I had to do a little science, and I mostly wanted to prove that I could do this, that I could link thing, but I love to watch the heartbeat. So I just want to sit and listen to this. And Steph, let me know if you can't hear this, but it should. I did.
The normal heart has two sides, a right side and a left side, and four chambers. The top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. Pulmonary artery splits into two vessels, each going to the lungs. As that red blood cell makes its way through the lung, it returns through the pulmonary veins to the left atrium. That blood is now oxygenated. It's picked up oxygen, then goes across the mitral valve into the left ventricle, which does most of the work in terms of delivery of blood flow to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
So that's just the general pumping. I just wanted to show that because I'm not sure everyone's basic knowledge of the heart, but something I want to tell you that I want to show you on here. So these lower chambers are the ventricles. These upper chambers are the atrium. In the female body, this ventricle wall is significantly smaller than the male, thinner. And so that affects some of our outcomes with coronary artery disease, and I'll get into that. But I just wanted to show you this. And also the ventricle, the left ventricle is smaller and proportionately in the female body. So obviously in general, females are smaller than men, but the heart in that ventricle is disproportionately smaller, if that makes sense. So that becomes a risk factor. I just wanted to show that diagram to you so when we get into our risk factors. How is cardiovascular system different in men and women? So we have smaller blood vessels and heart chambers, and this is what I'm talking about. The walls of the ventricles are smaller, the pumping chambers are also thinner, and that affects that the blood pumping. We have smaller vessels around the heart that feed the heart, making it more detrimental when you have coronary artery disease. Blood count, we have fewer red blood cells. As a result, we can't take in or carry as much oxygen. And again, if we are prone to anemia, we can't carry the oxygen as well. That's another deterrent. Cardiovascular adaptations, changes in altitude or body position are more adversely affect women than men, and they can lead to sudden drops in blood pressure. And then, of course, hormones. Estrogen and progesterone levels are typically higher in people assigned female at birth, while testosterone is higher. In men, actually, that's a typo. Testosterone is higher in men. So we know that estrogen plays a very big role in keeping our vessels very elastic, our blood vessels very more malleable, more stretchable. And when our estrogen is decreased in menopause and that starts to wane, those vessels become more constricted because they don't have that elasticity, which then leads to some vascular disease. I want to show you this because this is microcoronary artery disease, and it's really something that we don't have a lot of data on it. I'd say we've kind of been aware of this for about 15 years, but where men will suffer their coronary arteries, which is this main branch, this big trunk of the tree, that's a big blood vessel. And then of course it breaks off to these little miniature ones. In women, this microcoronary artery disease is much more prevalent. And think about it, if it's already a really fine coronary artery, if it's really small, and it becomes maybe less elastic because of the decreased estrogen, it is going to occlude quicker. It will clot quicker. It will constrict and cut blood flow quicker. And so you map that with a thinner muscular wall, it is not a good equation. And so it's really important that we are aware of this, because it is also what maybe affects how the symptoms are experienced in women versus men when there's a heart attack in play. So these are specific symptoms that women will experience. Chest pain, which of course men, we hear about this. We hear about that squeezing, crushing pain, like an elephant on my chest, like a vice around my chest. But women, more so than men, will have pain in their upper abdomen. They may not have that crushing pain. They may feel some discomfort. They could experience left breast pain, pain in their back and shoulder blades. That is a very prevalent sign in females specifically. So an upper back pain, neck pain also. We've heard about jaw pain or teeth pain. We've heard about pain in the arms, but that upper back, that shoulder, that abdominal pain are all things that we should look at. We hear about it feels very much like indigestion. And so how do you know what's indigestion or what's a heart attack? And my answer to that would be, let someone else decide what it is. Don't you sit and wait and decide. If you've had indigestion all your life and you know what the indigestion is, then you know. But if you've never had indigestion and all of a sudden you think you're having indigestion, let someone else make that determination and go and seek some evaluation. Symptoms of heart failure, you're going to have shortness of breath, which is that congestive heart failure where the heart is just not pumping effectively. Trouble exercising, you're going to have swelling, you're going to have edema. And we're not talking about puffiness from eating too much Super Bowl food on Sunday and then Monday you wake up and you can't put your rings on or everything feels, I'm talking about like unable to put your shoes on. The retention of fluid around your feet is really something, or a lot of shortness of breath because your lungs are filling with fluid because your heart's not effectively pumping that out. So some of the risk factors, high blood pressure is probably the number one, okay? More than 56 million women in the United States, 44.3% have high blood pressure, and that's defined as 130/80. So I encourage you to get your blood pressure taken. If you don't know what it is, get it taken. You can go to CVS, there's blood pressure machines there. Sometimes you can have a pharmacist take your blood pressure, but definitely we should be going to the doctor, because here's the deal. Heart disease is the #1 killer of women. 1 in 5 women will die from heart disease, some heart-related incident. We don't think about that. We go and get our annual mammograms, and we should, absolutely. We go and get our annual pap smears. We worry about our skin and getting our skin evaluated for skin cancer. We need to take measures to get our blood pressure taken, get baseline so we know where we're at. High blood pressure is often underdiagnosed in women, and fewer than 1 in 4 women with high blood pressure have their condition under control. And part of that is that some of the management with the medications, blood pressure is very, very manageable medically. And you can also do behavioral changes. But women experience more adverse effects from some of the different medications, and it's just sort of a trial and error thing that sometimes takes some time to work through. And so compliance and perseverance in finding the right medication for your blood pressure is just so important. Women of color are nearly 60% more likely to have high blood pressure than their white counterparts. And then this is very interesting. If you have ever been pregnant, and if during that pregnancy you had high blood pressure issues, or you developed gestational diabetes, or you had any cardiac complications or things that they were watching while you were pregnant, you have an increased rate of experiencing cardiac issues when you get older. There's a correlation. So it's just good to know what our risks are, that's the most important thing. Other medical conditions and lifestyle choices that put us at higher risk. A high LDL, that's the bad cholesterol, smoking, family history, diabetes, excess weight, autoimmune diseases, specifically rheumatoid arthritis and lupus, which are predominantly female autoimmune diseases, have a higher prevalence of heart disease. Unhealthy diets high in fat, high in sodium intake, physical inactivity, drinking too much alcohol, stress and depression. Stress and depression affects women's cardiac health more than men. So these are good things to know. If you look at this list, most of these things we can make behavioral modifications and improve our risk factors. If you're a smoker or if you vape, same vaping, they're also believing, time will tell as we watch that, but that is not good for you. They're seeing a constriction of blood vessels with vaping. So family history, we can't do anything about. Diabetes, we can't really do too much about unless we can monitor it and we can keep it as stable as possible. We can keep that A1C at its lowest level. Excess weight, we can do something about. Autoimmune disease, we can't do anything about. Unhealthy diet, inactivity, alcohol, all are controlled. So I want this to be an empowering thing. I want you to think about what you can control, and then let go of what you can't, but be aware of it. Know that it is there. It's just having all the information is your best case scenario. We also face specific factors related to reproductive health. You get your first period before age 11, that increases your risk factor. Menopause before age 40, whether surgical or natural, also increases. Polycystic ovary, diabetes during pregnancy, I mentioned that before. Preterm delivery, delivery of a low birth weight baby, or a high birth weight baby. So hypertensive disorders of pregnancy, and then cardiovascular conditions during pregnancy, we mentioned that. So these are obviously very specific to just women. Okay, so screenings and physicals. You need a blood pressure. You need a blood pressure checked at least annually. And if it's great, if it's a great blood pressure, then you're good. And if it's not, you need to continue to monitor it. Sometimes people have what they call white coat disease, where they get into the doctor's office and they're just a little amped. They're waiting for the results of some tests, or they have their blood work and they don't, or just the whole scene is stressful. So I would encourage you to really practice some mindfulness. And if your and they usually take your blood pressure when you first get there, when you're first brought in, but I would encourage you to ask your provider to take it at the end of the appointment as well, and see if it doesn't come down when you've had a reassuring interaction and it works. So blood pressure, annual, please, or if not more. Blood glucose and cholesterol levels, you should know, you should have that. You should know what your blood glucose, or really it's your A1C is what you want. So those are fasting blood works, a lipid panel. It will tell you your LDLs, your HDLs, your total cholesterol. You should get a baseline EKG from 40 on, earlier with a family history. You don't need it every year unless you've had some cardiac incident or concern, or you check a lot of risk factors. But with no risk factors, you should get a baseline EKG. And then the other test that's out there that's really non-invasive, it's called a coronary artery calcium test. I don't know if anyone's familiar with that. It is a CAT scan of the heart, and it detects calcium in your artery, the coronary arteries. And so, which would then lead to maybe that's considered plaque buildup, right? The thing, and then it's about a 15-minute long test. I actually had one done last year, and you're hooked up to an EKG. So they're watching the rhythm of your heart, and then you have this CAT scan. They bring you into this tunnel thing. It's not like an MRI. It just kind of goes around your whole chest. It takes about 10 minutes. And that's a really good indicator of where you are. There's this whole equation they put together, but where you are in your coronary and how much did they see and what is your percentage and how do you rank with the demographic, the same person, same age, where are you in that? And I'm happy to tell you that I beat my husband. So there's my competitive spirit. I'm going to show you this. I love this tool, and I will put this in the link. I will share this in the email, and I would encourage you all to give this a try. Here we go. Oh my gosh, it worked. I'm so happy. Okay. So this is a risk estimator that your primary care provider may use. And what you do is you literally go through and fill it all out, but you will need to know your systolic and diastolic blood flow. Systolic is the first number, diastolic is the second number. And then your total cholesterol, and that will all be on the blood work that if you get a lipid panel, which I highly encourage everyone to do, because you don't feel your cholesterol. You don't know what it is. So we need to get that. So HDL is the good cholesterol, LDL is the bad cholesterol, and then you just fill this out and continue on, and it gives you a risk factor of where you are. You're at a 10% risk, a 20% risk. And then from there, it's super helpful, and it kind of can relay or relieve a lot of questions for you. So I encourage you to play with that. Okay, so prevention. We need to be aware of our risk factors. So we should have an annual physical, annual blood work. We need to know where we're at, because that's our starting point. If we know that we have a family history, if we had anyone in our immediate family die of a heart attack, especially premature death, those are really important factors. Regular physical activity, exercise 150 minutes a week. So that's 30 minutes, 5 times a week. That's the recommendation. If you are only doing 50 minutes a week, maybe you increase it to 60 minutes. This is where I want you to be, proactive and say, what can I improve? Maintain a healthy weight, diet low in saturated fats, high in fiber, avoid foods with added sugar. We talked a lot about nutrition last month. I'm curious what landed for you all. Decrease or quit smoking, decrease alcohol, and drink in moderation. So these are all things that every single one of us can do, even if it's little things like I'm going to start taking the stairs and not the elevator, or I'm going to park further away from my office and walk an extra 5 minutes. Those are areas where just that movement, or maybe I'm going to walk really fast, like a little speed walker across campus. I mean, whatever it is that you can get up and move, that is only going to help you. And then these are my resources, of course, the Cleveland Clinic and the CDC. And then I just wanted to add like one thing that I found right before I came down here, and that was this European Society of Cardiology. And it shows that women have a 2 to 3 times higher rate of a negative outcome than men after having a heart attack. And so the theory behind that was that whole microvascular cardiovascular heart, that those little vessels are so important that you often don't have symptoms, but when they become occluded or from cardiovascular disease or coronary artery disease, the fallout is pretty significant. So it's just important to pay attention, to know your risk factors, pay attention to your body, and don't ignore it. And I think that is it. I'm going to stop share. Okay, I'm back. So I'm going to turn off our recording now, and I'm going to ask people